ladies and gentlemen, thanks very much, and you're all very welcome to the Health and Wellbeing Board of Wednesday the 7th of February at 2 p.m. And we are live to the world, so if you want to comb your hair or do up your ties, now is an appropriate time to do it. We're going to start off with the minutes of the last meeting held on the 13th of December 2023, and just a reminder that it's just an administrative thing to approve the minutes as opposed to comment on them and just correct any factual inequalities or inaccuracies. I'm going to bring you through the pages of the minutes of the last meeting, starting with page 1, page 2. We got how did you start it?
Hello.
Okay, go ahead.
It's just on the you've placed myself and Health Watch as under officers and colleagues in attendance. We're actually a full member of the board, and so I'd prefer if we're not put under that heading.
Can we, James, make all? Yeah, fantastic.
Okay.
Thank you very much, Sarah. Page 2, page 3, page 4, page 5. And I'm going to pass those as an accurate recording, unless anybody else has any further comments to make. All those in favour? Passed. Can we make a note of that, James? Now, there's a couple of replacements. We have, due to changes in cabinet, etc., had a change from Scott Carlton being replaced with Councillor Tom Smith. Councillor Tom Smith is sitting just directly in front of us. We also have had a permanent addition to the Health and Wellbeing Board as we have the new chair of the voluntary sector, Daniel King. Where is Daniel? Daniel, you would just give us a quick introduction for those of us who are unfamiliar with you and your role?
Yeah, so hello everyone. I'm Daniel King, Best Organisation Studies. Button. There, I press the button, magically it appears, yeah. So I'm Daniel King, Professor of Organisational Studies, Nottingham University. I'm the chair of the VCSE Alliance. Been in place for about 9 months or so now, and the Alliance brings together voluntary community and social enterprise organisations across Nottingham and Nottinghamshire as well.
Thank you, Daniel. And Daniel is taking up a vacant place that existed rather than something that's been newly created. The other important thing to notice is that we don't have a Professor Jonathan Gribbin here today, and it's one of those things that after 4 or 5 years he's stepped down from his role. His last act was to accompany me on a road trip to London last week, where we went to the Department of Health and Social Care and hand-delivered a letter on fluoridation directly to the in-tray of the Secretary of State for Health. Be under no illusion that should that be approved by the Secretary of State for Health for evaluation and public consultation, it could bring about one of the single greatest improvements in the health of children in Nottinghamshire in any of our memories. So quite a seminal point, and I thought it was really nice to be able to accompany him on that as his last act as the director, and I think it was absolutely brilliant. However, when all things past, something new comes behind it, and in this instance it's the acting director of public health, Vivian Robbins. Vivian, did you want to say a few words about your current status?
Yes, I can do. Thank you, Chair. And just echoing the thanks to Jonathan Gribbin for the great work that he's done for Nottinghamshire before. He will be sadly missed, I'm sure, across the system as well as with the department, so if we could formally thank him. And thank you to you both for the great work that you've done in terms of fluoridation work last week. That was a real milestone for Nottinghamshire, and puts us in a really good position to think around how we can expand our ambition to fluoridate the whole of Nottinghamshire for the future. In terms of interim arrangements, so I am Acting Director of Public Health, and for the moment there are processes going on in terms of recruiting an interim Director of Public Health, and then there will be a substantive Director of Public Health going in within the next sort of probably spring, summer time. So I will be acting and I'll be in that position for the moment, and then we will obviously let everybody know in terms of if there are any changes coming on in the future. So thank you all for your help and support through that time.
Fantastic. Can I call you Director Robbins now? Director Robbins. Excellent. Can we look for apologies for absence, James?
Okay, so we have received apologies from Colin Pettigrew, Melanie Williams, Victoria McGregor-Riley. Substitutes in place are Lucy Peel, and we do have a representative of Ashfield District Council, David Walters, in the place of the current vacant Ashfield position. Thank you, Chair.
Thank you, James. Declarations of interest. If anybody here present has any pecuniary or non-pecuniary interests, private or personal, that they'd like to declare on any items on the agenda, now is your time to make it known. If anything comes to you throughout the afternoon, just raise your hand and let us know. Fantastic. Item number 6. It's the Integrated Care Strategy for Nottingham and Nottinghamshire 2023 to 2027. And the report is there really to update us on the progress of the implementation of the strategy and its refresh and the joint forward plan. We're all quite excited to hear how it's going, and it has to be against the fact that demand management in terms of what we have to deliver for the people of Nottinghamshire through our strategy and the health inequalities management are uneasy bedfellows, and they will challenge us over the coming years in order to maintain the preventative agenda, the preventative strategy, and ensure that it doesn't fall off the end of any budgeting and be left to the end and be seen as the icing on the cake, rather than, as all of us know, prevention is the cake itself. So I'm going to go over to Joanna Cooper and Director David Briggs.
Yeah, I was making it hard by not having a name badge, wasn't I? That's deliberate for all those who didn't know. So, thank you all for reading the paper in advance. It's important to realise it's the first in a series of conversations to shape the current integrated care strategy, given time has elapsed, things have changed, and we're in a slightly different position now compared to what we were in before. This isn't the final and only opportunity for comment. There will be multiple more comments and opportunities, and in the paperwork it describes how you can make sure your voice is heard in the integrated care strategy, and then subsequently in the joint forward plan, the NHS response to the updated and refreshed integrated care strategy. Our integrated care strategy, I think, is really well owned, really well understood, and all organisations buy into the principles set out in that. And it's had a very extensive engagement, consultation, and a mechanism to seek views on it over the course of last year and during its development. So we're quite confident that many of the bones there are the right bones. However, there will be things that have changed and priorities will have changed slightly. It's important we reflect those in an update version. And colleagues from across the system have been integral into some of the work that's gone already into the refresh, but also into how we can take your views forward and put them into it. This is, from a health perspective, the most significant document that we produce. It guides everything that we do, and it's informed by and takes account of the health and wellbeing strategy
and the health and wellbeing priorities as an integral key feeding document. So the work that we do here in this committee is integral to the development of that strategy, and that strategy is used by all health organisations in creation of the joint forward plan, which is how we as a set of the health community shape our services over the coming years to meet the needs of our populations and help us in this sort of forum develop those joint programmes of work which we know have such a beneficial impact on our community. A couple of things have changed since last year. Many partner organisations in the ICS are under quite significant financial pressures, both in the local authority but also in health, and we need to take account of what those pressures mean in terms of our strategies and reflect them in, but it shouldn't really damper our ambition around some of the joint opportunities that we face. And indeed, experience shows that some of the greatest changes can be made in spite of financial challenges. And my experience has always been that the health sector in particular responds very favourably to financial challenges and really thinks about how it can transform rather than how it can do more of the same. So I think we see this opportunity of the financial challenges that particularly NHS is facing to think about a wider transformation programme. And indeed colleagues I've spoken to in the NHS and in the local authority really recognise that as an opportunity we need to grasp. The process is that we're here to talk about the ICS strategy refresh. We've got another meeting later in this calendar and schedule to talk about the joint forward plan, the NHS response to the ICS strategy. So not only will we have an opportunity to shape the ICS strategy, there'll be a formal opportunity and multiple opportunities in other settings to help us shape that joint forward plan, because the partnership approach is really critical in delivering that. There are a number of examples in the paper around where we think we've come and delivered with elements of the joint forward plan and the ICS strategy, and there's an example on the screen there. There's lots of these. My take is we're still emerging in this way of working, as you'd expect, from a fairly new strategy, and we're learning how to work really effectively together on those things. And this, to me, is a really good example about how we can help people go home when they're in a hospital setting in a more efficient way. We know that if we do that, people will be much more likely to be independent, not have to have carers, and also their long-term outcomes are, i.e. their chance of having less illness, is significantly improved. So that joint working not only benefits our population, it's also got quite a big beneficial in terms of finance and activity. In other words, it's not as expensive for the NHS and it doesn't bake costs into adult social care by having prolonged stays. My personal commitment as part of this refresh is really to listen about what's important to all stakeholders, make sure we've got that right. I think we need to play a bigger part in terms of personalisation. In other words, what people would like, what's important to people, to individuals and their carers, and that be slightly stronger in the way we do business going forward, learning from colleagues at the local authority. And that strength-based approach that we started to implement as jointly, I think, is really starting to bear fruit. I think that needs to come out really strongly in it as well. Really keen. I don't talk for ages about some of the great work we've done, because I think we all recognise there's a very long journey to go on this, and we've only just started. It's not. I'm not saying here that we've got it right, but I think we're all committed to it, and we started to make some progress. So if I pause there and hand over to Joanna to talk for us the slides about how you can get involved, how you can feedback, and how we can get this document reflecting all of the sorts of things that we want to see in there. So Joanna.
Thank you, Dave. For those colleagues that don't know me, I'm Joanna Cooper. I'm Assistant Director of Strategy for the ICB, but I'm very much the holder of the pen. It's not things coming from my brain. I need all of your collective input and colleagues from around the system. So integrated care strategy then is a bit of a reminder on the screen for you, which a diagram I hope you're all really familiar with, showing those 4 aims of the strategy and the 3 principles that we embedded throughout everything that we're doing around prevention, equity and integration. Our integrated care partnership came together last year, and they approved the very first strategy for the system in March 23, and they'll be meeting again later in March 24 to have that light touch review refresh of the strategy, take stock of where we are and reconfirm our vision for the year ahead. And as Dave said, alongside this, there's also that refresh of the NHS Joint Forward Plan. We can't refresh one document without the other, because that's our delivery plan for how we will make the strategy come to life. Can I have the next slide, please? Thank you, Lizzie. So on this slide, there's again a reminder. It's probably a little bit small on your screens, but it's the 14 priorities that we highlighted within the strategy as our key areas that collectively would make a difference to system partners and to the local people and carers in our population. It'd be really helpful for today's meeting to focus on that impact of the strategy and how, as Health and Wellbeing Board, are you still supportive of those vision, the principles, the priorities and the principles that we've embedded into the work. And I could have the last slide, Lizzie. So this is a reminder of recommendations in the paper. We can have a conversation today about the strategy. That'd be really helpful if you do have any immediate thoughts. We are still taking feedback up until the 1st of March. So if there's anything that you think of outside of this meeting, or you're not in another forum where there's a conversation about this, please do feel free to email, and I'm sure that Lizzie can collate that feedback from members and feed that back into the process for us. So the 4 recommendations in the paper, that first one is the review of the strategy, and then recommendations 2 to 4 are around the next steps. So ensuring that there's ongoing engagement in both the development of the strategy and of the Joint Forward Plan, and be really helpful if we can agree that delegation to the chair and to our acting director of public health, just to make sure they're more involved in that day-to-day nitty-gritty of developing these documents, and having those 2 workshops so that we've got more time with you to discuss in more detail in your March meeting about that Joint Forward Plan, what's changed, what do we need to shape further, and having that formal endorsement in April. So thank you again for having me, and back over to you, Chair.
Yes, indeed, it will be. I'm going to ask if anybody has any questions. Now is your opportunity. Councillor Wilmot.
Thank you, Chairman. First of all, congratulations to the team on the work provided so far. They're very, very good, seem very, very good priorities, although there's a lot. So it's going to be difficult to get all of them done in the time scale that you've put on. Just a few observations. You said that you've been allocated a further financial of £1 million of additional funding for public health grant from your public health grants, and it says that you'll be helping more the disadvantaged and those that are homeless. I just what sort of new projects that you actually, was it projects that are already ongoing? You're just putting more money into it. That's question 1. The next question is all about the habits of smoking and tobacco. It seems that you're doing a lot of good work in that situation, but I'm more interested in a prevention type of schemes, and I think that children and young people are the people initially to go and see, and the only way to do that really is in schools. I just wondered if you tell me if you're going to do any work in the schools on that. That's an item. As I say, supporting children and young people to have the best start in life is absolutely essential. So I do hope you do continue in that vein, because our children are our lifeblood, and that they will be looking after this, in England and all over the world. Our young people will be coming up and taking it over from people that are in post at the present time. So it's essential that they get some knowledge, because we are lacking knowledge at the present time. It seems to be in lots of things, and we need to make sure that the children get an opportunity at an early stage. Also, you've got to establishing the clinical priorities. I thought you would have still added. I know it's got its own area, dental care in schools, but the position is that dental things that go wrong can accumulate to something else. It can become cancer or other issues, So I think you should have that in your clinical priorities, because it can go on to other things that would involve hospitals more. And also, I'm just saying that you're saying that you're going to support 250 young people into work, and that you would have that information by January of this year. It's now February. I just wondered if you'd give me any information on how many people of the young 250 haven't actually got jobs. It would be very, very nice to ask that. And finally, just to say that you say early results are anticipated by early 24 to support ICP discussions. I just wondered if there are anything that you could update us on some of these early results of many of the projects that you put forward, of the 14 that you put forward. And with that, Chairman, I think I've said enough.
I think you've done very well there, Councillor Wilmot. There's a lot of questions in there, and I suspect there will be different people with different skill sets to answer those. So if people want to answer the bit that they feel is appropriate for them, then there will be others that will answer, particularly around the smoking in schools, etc. David?
Yeah, so I think lots of people will have lots of questions about how much have been delivered. And what it's going to do is take an opportunity of get that feedback in one go, and rather than give us a very high level answer, I'd quite like to feedback individually or as a group in writing some of those answers. So I think taking note of what you said, I think it's really important actually. But we'll also, clearly it's really important, isn't it? So what I think we need to do is, rather than try and give a superficial answer to some really important questions, let's just take those away, and others will have it, and perhaps in writing we'll maybe bring something back in terms of an update on delivery. The focus here today is to hear about priorities, really. So I think a number of some of those areas where you'd like to be considered as priorities, I think we can feed that into the process. But in terms of delivery to date, let's do that at different points with a different group of people, I think, who will have much more operational detail about the impact for young people and employment. And I don't think anyone would have those answers here today. So rather than try and answer them, we'll bring that back in writing with a group of people who can answer that a bit more specifically for you, if that's okay.
Thank you, David. I'm just going to go behind you for an update on the schools and smoking, etc.
Thank you, Councillor Doddy. So, Councillor Wilmot, just to address the issue in relation to smoking in schools. So, we have a programme that we're rolling out in schools called the Intent Programme, and that's to support young people in preventing the take-up of both smoking and vaping. And it's a whole school approach that we're adopting. At the present time, we've got 12 schools that are engaged in that, 12 senior schools that are engaged with that. And that's being delivered through our Tackling Emergency Threats team, who are based in the County Council, that deal with the Healthy Schools agenda. So we're starting to see traction in that area, which I'm particularly pleased about. I agree with you that prevention message is very important. Thank you.
And that just builds on the government's bill in the King's Speech on preventing the legal sale of cigarettes to anybody who is currently 14, with the ban coming in on the 1st of April 2027, and more recently the ban on single-use disposable vapes, of which something like 20% of as 11+% of them are habitual users. And focusing particularly on the fact that they're fancy flavours, multiply coloured and priced in such a way as to attract children, and therefore the approach not only is the banning of them, but the making of them in uniform packets like cigarettes, perhaps taking them off the front counter and making them more difficult to achieve. Vaping is a facilitator to help those people who smoke to stop smoking, and it's very useful in that instance. But we do not know the long-term harm impacts on children of vaping, etc. And we do know that nicotine is an incredibly addictive product, and I think we will welcome the single-use disposable vaping ban, which is going to come in under the government, and hopefully by 2027 the smoking ban. Vivian Robbins.
Thank you, Chair. So just to address some of the elements, so thank you, Kath, for addressing some of the stuff around the smoking in schools. In terms of some of the work around homelessness, Councillor Wilmot, we will be picking up some of that in the severe multiple disadvantage workshop in a little bit. So it's just to assure you that we will pick up some of that in a little bit, but we are doing a lot of work around this in terms of some of the services that we commission in terms of supporting people who are experiencing homelessness, linking in with some of the rough sleepers initiatives, and you will probably learn around an initiative around making every adult matter. So we are doing quite a lot of work in this area, but if it's helpful to have a conversation offline in a second, then more than happy to do that with you. Thank you.
Thank you. I'm going to go to Helen Smith.
Thanks, Councillor Doddy. Just 2 points really. The 14 priorities, as you say, are a lot of priorities. I think it would be really great to prioritise a couple of those for this year, and I'd really recommend making every contact count them, because I think if we can change how people work with people, we'll have a big impact on a lot of those other priorities. So that would be my request to that. And then the second point was one of the questions for this group in terms of a session about the joint forward plan in March. I think I'd like to see that as a joint one around how we're delivering the health and wellbeing strategy, as well as, because we'll get otherwise too much of an emphasis on the NHS part rather than all our other colleagues working to deliver the strategy.
Yes, indeed. Medical Director David Briggs.
Yeah, I think one of the challenges of refreshing a strategy, even a refresh 1 year into a 5-year plan, is that it looks like you've got to sort of toe the line a bit for some of these things, haven't you, in terms of how long it takes to deliver some of these. So I think bringing an update about where we are is really important. Just on the priorities, the evidence is showing, so nationally and locally, that one of the things since COVID is that premature mortality. So these are people under the age of 75 dying of ischemic heart disease and increasingly liver disease. And that's one of the sort of standout features of that we can see. So making every goal count, looking particularly at alcohol, cigarette smoking, and prevention of cardiovascular disease, I think it's got to be a priority that we actually do something fairly significant about this year. And the second is in terms of the future need, how we are choosing as a society and as a system to support older people when they become more frail, I think is critical as well. Not only for the experience for them and their families, but also for the challenges that gives to the delivery of services in a timely and high quality way. So I think those two things really stand out as something that, the evidence is saying we've got to do something about fairly seismically in the next 12 months. So I'd strongly support that. Making sure they're all there, but where the amount of focus we place on them is really important. Clearly children, if we want a good future, we need to make sure we do something around those aspects. Thank you.
Councillor Penny Gowland.
Thank you. I think to some extent I was going to agree with Helen's comments. The 14 priorities, I assume I'm looking at the right thing. Some of them seem very vague. We will support children and young people to have the best start with their health and so on. Do we need to write that down? The idea of supporting the 20% most deprived was obviously a much more specific focus. And I mean, recently we've heard about the lack of health visitor visits now, and it feels like, and I appreciate if you're in the health sector and you're trying to deal with acute problems, diverting resources to prevention is difficult. But it feels like some of these aims are very vague. Making every contact count stands out as being specific. And there's some others that are very specific, like this single health hub for recruitment, health and care hub for recruitment. But some of these do seem really quite vague and possibly distracting. And it feels like they should be tightened up to me.
David?
Yes, so supporting this is a series of outcome measures, which I can give you the granularity. We did present those, I believe it was in December, and we'll happily share those around. So what, for me, is these are often ways of working. Underneath that are key granular targets. So we will improve healthy life expectancy from X to Y. We will reduce this from that to that, and those will have all been agreed. And I think sharing those will give you what is it that we're trying to do with the statements. I think that translation would be really helpful, so we'll share those.
Vivian.
Thank you, Chair. So echoing many of the comments around the board today, I think we've got a really good platform here. We've got a really good opportunity, and I suppose there's something for me around how we maintain that opportunity and we build on the strengths that we've got, acknowledging we are in difficult financial positions for a range of organisations across the system. So I suppose there's something for me around, one, being very clear around the priorities, and I would absolutely echo the support around the making every contact count, because I think that really is around embedding strong building blocks for prevention and equity across the system, and really making sure that we don't lose that focus on prevention when times are tough. But I think there's something else for me around, we must not forget that the children are our adults of tomorrow, and giving them the best start in life has such a strong evidence base. So I suppose there's something around building on some of the comments around, is that specific enough in terms of the tangible things that we're going to do? And I think maybe in the workshop that we will do in March, there's probably something around how do we consider the links between the Joint Forward Plan and the Health and Wellbeing Board, but being really clear around these are the 2 or 3 key things that we're going to see change over, and what will that look like? So I suppose for me there's something about really embedding the principles of prevention, equity and integration across our system, and really holding ourselves accounts to that, and be very pleased to support in terms of if there's anything that we can do to be able to make that happen. So thank you.
Sarah Collis.
Thank you, Chair. Mine's a bit of process question as well as comment. Obviously, from the paper, one of the things that we'll have to do, and that will be yourself, I would imagine, Councillor Doddy, is give our statement of opinion as part of the national guidance on this. I'm just a bit confused. We'll have a workshop in March which is looking at revisions. So there's a process to feed in before those revisions are made, and then we'll have a statement that this board will own on the plan. Is that right? Looking.
Go ahead, John.
Can you hear me from there? Brilliant. So the 2 documents have 2 slightly different requirements behind them. So integrated care strategy is owned by the Integrated Care Partnership, of which some members of Health and Wellbeing Board are also members of that. So they will be undertaking that review approval process. Joint Forward Plan is slightly different. In the guidance that we've received, there's a specific requirement for Health and Wellbeing Boards to support the plan and to confirm that the plan articulates what's in the Joint Health and Wellbeing Strategy for the city and for the county. So we have a small section at the end of that, which I think we agreed a couple of lines last year to put those into the plan. So we'll go through the plan in more detail at that March workshop.
Thank you.
Thanks for that. Can I just, I'm sorry, I've not finished.
Go ahead.
So echoing, I think, what's already been said, and particularly what Viv just said around understanding those those golden threads that run through the strategy, I think is really important, considering the financial difficulties, as you mentioned, Vic. And I think for me, really seeing where health inequalities is being impacted and understanding where prevention. Now, I absolutely see the point of we've got to prioritise the priorities, particularly as things start to get tight from a financial point of view. But I think having seen prevention be something that potentially could be very much hindered by the financial position, particularly within health, I wouldn't like to see making every contact count be the strategy for prevention, because it's not, doesn't go far reaching enough. And I think, you know, we have to keep an eye that we're not losing sight of the prevention agenda throughout, and that it is seen as one of those strategies underpinning golden threads to the strategy.
Yes, thank you, Sarah. And it was only last week that Professor Sir Michael Marmot said that between 2011 and 2020, 1 million premature deaths occurred in people living in the most disadvantaged parts of the country. And went on to further say that it was only by analysing through what he called a geographical lens at the level of the community that we could identify the inequalities that lead to the premature deaths in those people with the greatest health inequalities. And I think that's really what you're talking about. How do we reach out to that million people and actually reduce that inequality? Councillor Crosby.
So there's lots of documentation around. However, I think you're right in terms of how we manage to explain this to all of our teams is really crucial to get real buy-in and ownership for a number of these things. Now, I'm not sure what we've done to date. Some people might have an idea, but whatever we've done, it clearly hasn't gone out quite widely enough. Otherwise, the question wouldn't have been posed. Now, I suspect we always need to do more work on that, actually, because it's not an easy conversation. It's not an easy thing to share. And we'll need quite a lot of thought, wouldn't it?
We have two more speakers in addition to Vivian, and then we're going to go to the recommendations. Vivian.
Apologies, I'll be brief because I'll just pick up on Dave's point. So we're doing a lot of work within public health about really understanding what the building blocks of good health are, because we know that if people have good building blocks, so good work, good housing, good education, good communities, for example, that actually contributes more to their health and well-being than accessing services, which is actually only contributing to about 20% of their overall health and well-being. So there's something for me around how we're doing some work around the narrative of that in the department, but we're thinking around how we link that into some of the work around making every contact count. And that needs to be a system approach across a range of organisations to have the greatest impact. So it's still in its early stages, and it's got to build on a range of approaches that are already happening across the system in terms of the strengths-based approach that we were talking about, trauma-informed care, and some of the work we were doing around SMD in a second. But we would be absolutely keen to get districts and boroughs absolutely integral and part of that as part of our broader system partners, because we will have the biggest impact if we work together on that. That would be fantastic. Thank you.
Thank you, Councillor Crosby. Councillor Schutler.
For clarity, it's Councillor Schuler. In terms of the preventative agenda and national fund and the additional funding that has been brought on board, do we feel that there is enough finances to meet the priorities, and will this enable us to prioritise the health inequalities innovation funding that was recently shelved? And also in terms of the smoking prevention, it was talked about that 12 schools have taken on board the Healthy Schools agenda. Can I ask if all academies in our in Nottinghamshire have actually engaged with the Healthy Schools programme and are actively looking to become healthy schools?
Now, who would like to do the update on HIF and the most recent release on what those monies are going to look like in the next 12 months, particularly around the approved plans of the place-based partnerships, etc., to enact the very preventative agendas that we're all talking about today? Director David Briggs?
Yes, so if I bring up the health innovation investment for the things. First most important thing is it's a relative, isn't it? Compared to the overall spend of the NHS, it's not a large resource. And actually the combined people who work in the NHS are a much bigger resource. And the challenge of the ICS Health Inequalities Board was, if those people did different things in a different way and a different focus, would have a much bigger impact than any form of investment of this scale. This is really a way of trying to generate new ideas, new ways of working, rather than being the solution to health inequalities, which such a small fund clearly could never do. In terms of the fund for this year, the 4.5 million that was approved was fairly late in the year. Most schemes, many schemes had underspent and weren't able to spend all of it, and some hadn't made any commitments yet. So those commitments that were already in place have been honoured, and letters went out, I signed them today, to continue as planned. And some have had a very short slip into next year, so we have to start slightly later, and that's due to the quite marked deterioration in the NHS financial performance and the inability to spend outside its resources. So recognising its priority, and there will be funds allocated again for next year. So it's planned to be spent again for next year. Some have been slipped by very small amounts of time into the beginning of next year, but those who have already started and have got planned spends have been continued as planned.
Could I just draw you out on the 5-year cumulative funding for prevention, thought originally to be just over the 4 million, but eventually thought to get up to as much as 30 million a year on prevention? Is that still the plan?
May I answer that? The ICB is committed to move more of its investment into preventative measures from treatative measures. That's a given.
Yeah.
The challenge is, at the moment, the spend on healthcare services is exceeding the budget that we've got available to spend on it. The reason for that is really clear. The reason for that is a combination of inflation, a combination of increased technology and innovation, a combination of the needs of the population outstripping the growth. The only way that we can actually move to spending more money on prevention is if we deal with the intelligently and together with the pressures and demographic changes that we have on our population. And that is predominantly how people with more complex care needs are managed in the health and social care system in a way that's more personalised, more carefully planned, and more supportive in the community. And that isn't an easy thing to do, otherwise we would have clearly done it by now. We need to engage with a lot of staff, but we are emerging a plan as a system, with that as being one of the major focuses and will be one of the major planks of the Joint Forward Plan, how we work together to work with families, individuals and carers of those with more complex needs in a way that reflects their strengths, their community strengths and their needs. as opposed to de facto being a secondary care type appointment. So as we make more roads into that, we will be able to make more roads into prevention. But as it stands here now, we have not delivered a balanced financial budget in the health sector. We have had to agree a different control total with the central NHS England to allow us to end the year. We will now need to recover that position over the next maximum of 2 years and reduce what is quite an extensive deficit, particularly in the acute sector. So, recognising those challenges, there are a number of opportunities, but we will only achieve those opportunities by working very closely together on some very specific issues that I'm sure will be a lot more clearly described in the forward plan as we develop that jointly with colleagues in public health and colleagues in social care.
Thank you. Councillor Title.
The second part of the question wasn't answered about the healthy schools.
Oh, I do apologise. Yep.
Yeah, thanks for your question. I don't have that data available now, but I'll make sure that the Tackling Emerging Threats team let you know about that difference, or whether there's a difference between academies and local authority schools.
Thank you. Councillor Tideswell, and then we're going to go to the
Thank you,
recommendations.
Yes, Councillor Wilmot actually hit the nail on the head when he mentioned prevention is definitely better than cure. The thing is, how do you actually prevent places like early learning centre having to have more financial cutback? How do you help all the NHS having to put up with the stagnation? How are we going to improve it unless we've got full integration, especially even in suicide and everything else? Police, the health service, social services, schools, and early learning centres, and all those bodies that have that innate possibility of sorting out and relating to these actual problems. We cannot do it on a shoestring anymore. It needs to be fully integrated, and we need to make sure that all the bodies we take on board are fully integrated as well.
Yes, I seem to remember trying to get the fire brigade and the ambulance service to integrate like an American Chicago fire type thing, where they would have paramedics on board, etc. And not an easy thing. But full integration would be a great aspiration. But I suspect that it's beyond our forward vision at this moment in time. I'm going to move to Vivian to say the last word, and then we're going to move to the recommendations. Vivian.
So I think there's a range of comments that we can take back, and I will work very closely with our ICB colleagues to make sure that they are reflected in that. So I think, just echoing what Joanna was saying, this is the start of a conversation in terms of this refresh. So please do engage in that. We will bring that draft back in the March meeting, and then we can have some further conversations. But I don't know, Joanna or Dave, if you wanted to add anything onto that.
Right. No, thank you for your comments, and they were clearly forming that, and the frustration about needing to do some of this really quickly has certainly been felt, and one of my frustrations as well. So we have heard that, and in terms of the integration point that Councillor Tideswell just made, there's a significant greater amount of integration now than there was this time last year, and I would like to see a significant more integration by this time next year, and pacing that integration at an optimum rate is really important. We have to see systems go too far too quickly and integration break down. So recognise that one of the golden threads, I think, that other colleagues have brought up, is that ensuring that we are working really closely together on these big issues is a point we will absolutely make sure to take account of in the narrative and the construction of the document. Because I personally believe that if we don't do this together, we will miss loads of opportunities and we won't progress anywhere near as quickly as we could do if we did. I know the leadership within the ICS is as passionate about that as you are and I am.
and we have a statutory duty, Councillor Tideswell, to hold the ICB to account for the implementation of the jointly agreed strategy. I'm really looking forward to the workshop in March. With that, we're going to move to the recommendations to provide comment regarding the strategic priorities for consideration of the ICB, to agree to delegate ongoing input for the Health and Wellbeing Board regarding the review of the ICS and the refresh of the Joint Forward Plan, agree a scheduled workshop in March 2024, and to agree to schedule an item in April for the Health and Wellbeing Board for the formal statement of the draft revised NHS Joint Forward Plan. Thank you all for your comments. All those, I'm going to move that. Have we got a seconder to second it? All those in favour? Excellent, thank you. Now, time is not our friend today, as we've got a workshop coming up very quickly on our heels. So I'm actually going to move very, very quickly to Safia Ahmed, who is with us in the council chamber, to put forward a mammoth piece of work which has been done on the suicide prevention chapter, so it can go on our Nottinghamshire Insight website as an updated chapter. I'm going to go straight over to you, Safia. Take it away.
Thank you, Councillor Doddy. I'm Safia Ahmed. I'm a Specialty Registrar in Nottinghamshire County Council. I'm really pleased to bring the Suicide Prevention JSNA to board today for approval. The slides that Lizzie is presenting for me, I'm just going to run through the approach taken for the JSNA, some high-level unmet needs, and also the overarching themes in the recommendations, of which there are 19. And I'll try and go through this within 5 minutes. I first wanted to highlight that support is available for anyone who needs it following today's discussions. This is Nottinghamshire County's suicide prevention branding that you can see on the slide, and within it we've got the crisis line's contact number, but also quite simply you can text the word NOTS to 85258 to access free advice. Outside there are also resources, cards, lanyards with QR codes for getting support if needed. If you can get the next slide, Lizzie, thank you. So yes, just to share the approach taken, I think what I'd like to draw your attention to really in this slide is that the JSNA did involve local partners working together to understand and agree the needs of Nottinghamshire residents. I in fact convened a task and finish group which had partners that contribute normally to the Nottinghamshire and Nottingham City Suicide Prevention Steering Group. So within the partners were Nottingham and Nottinghamshire Integrated Care Board, Mental Health Commissioners, County Council Public Health Teams, Nottingham City Council Public Health, the local Nottinghamshire Healthcare Foundation Trust, and voluntary sector organisations as well. But I guess another key part of this slide to draw your attention to is the fact one of the unique assets in this JSNA is that we've got the local real-time suspected surveillance data, which wasn't around for the last JSNA in 2016. So this data system is reported directly from police to public health from next of kin at the time of suicide. So it's very timely sort of data that we were able to analyse fully for this JSNA. But of course, we also relied on nationally reported data and what's effective in suicide prevention, and also locally what assets we have within Nottingham and Nottinghamshire. Next slide, please, Lizzie. Thank you. There's quite an exhaustive list of needs that we think could be strengthened in the document. So I just wanted to pick a couple for the sake of time to look at. The first, which you'll see there, is we established that there was a need to link some of the core data sets that we use for suicide prevention to inform the prevention action, essentially. So better links between partner organisations, but actually also within organisations. So for example, within public health, the mental health team to share insights with the domestic abuse team or substance use teams. So risk factors that we know increase the risk of suicide, there's better insights shared. So that was one I wanted to just highlight there. Another would be school-based mental health support. We've established from the JSNA that vulnerability to suicide does start early, and actually many of the protective factors can be actually facilitated through school settings. So we work quite closely with colleagues to establish that we need an integrated whole school approach to suicide. So I think I'll just highlight that from this slide for the sake of time. Is it okay to go to the next? Thanks, Lizzie. The next two slides were just looking at a very sort of high-level snapshot for the recommendations, of which there were 19. But we did get them fitting into 6 themes, 3 of which are on this slide. So improved data and evidence. I've spoke a little bit about that on the previous slide. So we ask improved data sharing protocols and embedding learning across key partners. Reducing access to means is another core theme. So we'll be continuing to strengthen all the good work that happens through our real-time suspected surveillance working group. The last theme on this slide you can see is providing tailored and targeted support to target groups. So we found that I've already mentioned children and young people and adopting whole school approaches. We also have other at-risk groups such as men in midlife, which we are hoping to co-develop services with, and that's upcoming pieces of work from the partner organisations where we will be sharing learning. So just putting you through those 3 themes, and I'll move on to the next slide, Lizzie, if you can. Thank you. So the further 3 themes were addressing risk factors for suicide. So the risk factors included those who are financially vulnerable, unemployed, people with a gambling problem, people bereaved by suicide. There was quite a long list. So I'm just trying to recap here that we acknowledge that we need tailored support for these groups to access services, and that will be achieved by partnership working. Effective crisis support was another theme, the 5th theme. And actually we worked directly with the Integrated Care Board, mental health commissioners, to look at where potential gaps were, and there were gaps from ED support and crisis care, which we are working with them with, and we've got 2 recommendations around. And the final one here is around online safety. So there has been increases in suicide-related internet use from 2011 to date, and this is also a spotlight has been shone on this from the new National Strategy for Suicide Prevention released at the end of last year. So we'll be adopting national guidance on this. And go to the last slide. I just wanted to mention before I finish the presentation that the Joint Strategic Needs Assessment will be used as a tool in our strategy formulation, which is going to be coming to board in May of this year. That will be one of the real assets we think to driving the work, but also crucially the other 2 parts of the chain you can see from this graphic here is how we're going to get the lived experience within the strategy. And actually it's going to be formalised in a suicide prevention charter, which is a task and finish group of people with lived experience of suicide who are developing the charter, and that will be, we've already mentioned today, the golden thread through our strategy. We're also using learning from other projects with at-risk groups, with men, with those with financial trouble, gambling, with other at-risk groups we've highlighted in the JSNA. Thank you. I think the last slide just asks, yes, the Health and Wellbeing Board to approve the JSNA and support implementation of the recommendations within the context of the new Nottingham and Nottinghamshire Suicide Prevention Strategy, which will come in May. Thank you.
Thank you, Sophia. We do have a follow-up in May, a suicide workshop to follow up on the 19 points that you put forward there. And just to echo that the months of work that's gone into the production of this 112-page document is quite amazing. In years gone past, we wouldn't have seen 8% of suicides linked to webs. We wouldn't have seen it at all, or it would have been 1 or 2%. It's a staggering new figure to appear as a cause of suicide on anybody's list. Do you expect that to remain static? Do you expect it to grow? What do you feel about that?
So actually, when we look at the National Confidential Inquiry into Suicide Deaths, so it's an audit of deaths from 2011 to 2020, they have seen a general increase year on year in suicide-related deaths. So the quote you mentioned, the 8%, was actually taken from that data but just to make you aware that there were slight increases year on year. So it's quite difficult to say really what we're going to be seeing from this point forward. I mean, I think it's very positive that the new national strategy has highlighted online safety as a key priority, which is why we've included a recommendation to get partners to fully endorse what is coming from the national guidance. Quite difficult to talk forward back and perhaps explain what's happened up until this date, which is generally an increase.
And the American Senate had Facebook and Mark Zuckerberg and X and Twitter and all of those people before them in the last couple of weeks demanding exactly the same thing, safety for the children. Yes, go ahead.
If I could just add to that, colleagues may be aware that there's now an Online Safety Act that was received royal assent in autumn last year, and Ofcom are the key regulator around that. So increasingly we're seeing additional sort of legal basis to help support what goes on the internet and what people can access from the internet as well. So just for information, thank you.
Director Robbins.
Thank you, Jan. And I just wanted to reiterate my thank you to Sophia and Kath and the team for a really excellent and thorough piece of work. This puts us in a really strong position to really tackle some of the root causes around suicide, because as you've highlighted really eloquently, suicide is preventable and it affects those that are committing suicide themselves, but also really affects those family and those communities around us. And I think there's something that we really need to think around in terms of how each of us around this health and wellbeing board has our part to play. So I really look forward to what you bring in May, and I'll be really keen to think around what are the specifics that we can all collectively bring to the table so that we can do our bit to prevent suicide and really do everything that we can, because I think the key thing is here that suicide is preventable and we all can do a bit and help. So thank you for the good work, and I look forward to seeing the strategy in May.
Thank you. Councillor Anderson.
Thank you, Chairman. I'm attending the Not Alone workshop tomorrow in Newark at the YMCA Newark and Sherwood Community Village. This will focus on young people's mental health and wellbeing. How is the JSNA strategy suicide prevention being used in conjunction with the disproportionate number of suicides within the looked after children population? And I just wondered, is there any joined up thinking on this matter between the relevant partners of health and education? Thank you.
Yes, with the Not Alone website being an award-winning Nottinghamshire creation and enormously well used, how does it fit in with the preventative strategy?
Thank you for that question. We actually worked quite closely with teams within the Integrated Care Board, specifically the Children's Looked After Children team, who actually highlighted that they found a gap in services for children, particularly looked after children accessing crisis care. So we actually have developed a recommendation specifically around exploring that, and we're going to be working quite closely with the children's team, specifically looked after children, who highlighted this gap to us.
Councillor Schiller.
Thank you. Mine's in a similar vein. In linking the unmet needs of 16 and 17, I wonder, do we fully understand if there is any additional need in terms of young people with SEND, and would this be a factor for consideration within the risk factors?
So that's for children with SEND. We acknowledge that within children and young people there are very much different at-risk groups. You've mentioned one of them, which is SEND. The other group is sort of children who self-harm. The other group would be, for example, LGBTQ plus groups. It's a very, very broad children and young people, in a sense, is this umbrella which we have to focus on particular groups. I think by adopting a whole school-based approach, we will be trying to explore the differences and tailor approaches to each aspect of children and young people. I think you've mentioned SEND. I also think neurodiverse and neuro sort of autism, that was a group that we needed to explore a bit further. So actually what we would like to do is we've got listening events that have been commissioned in the springtime by Harmless. So actually we're going to be looking at children and young people and carers and parents of children and young people who self-harm, and actually getting from a lived experience really from them to help guide how do we tailor support for those people. Unfortunately that work was just out of the scope of this JSNA, but obviously being a partnership group, they're going to be sharing that learning with us. So hopefully we can try and meet the needs of all the different umbrella groups of children and young people.
So just very quickly then, so will you do any comparative data as to how many children and young people you get responses from that have an SEND? Because you talked about the neurodiverse, and yeah, that's really important because that's part of the SEND really,
yes,
isn't it? So
yes, I think that's the reason we've got that group as a specific listening event. So it's going to be a neurodiverse listening event just with children who have that diagnosis. So I can't really tell you a bit more about a data angle apart from that we're engaging with them and embedding any learning that we get from that event. I can go away and try and source some more information on it. I think that's all I can add at this point.
And we've got a neurodiversity JSNA coming up, including autism, etc., in the coming weeks. Lucy Pell.
Thanks, Chair. I just wanted to respond from a children and families perspective. I'm subbing for the corporate director this afternoon. So in terms of social care, our engagement in this agenda, we have a partnership-wide children and people's mental health local transformation plan and group, which of course has an overlap with the work of the JSNA recommendations. So fully engaged and fully supportive of the work. And I think in terms of both taking that whole school approach, but also we've got particularly vulnerable cohorts, making sure that we've had lots of ambitions and aspirations in place around how we can better meet the needs of those children and young people. But I think this presents a real opportunity to enable us to see some of that through to delivery, particularly in terms of those looked after young people who we know experience particular challenges. In terms of children and young people with SEND, we're doing a lot of work to improve the experience and outcomes of children with SEND as a local area partnership. So that's existing work in terms of led by the council and the ICB. And I think within that there's a data work stream that we're looking to better understand the needs of the cohort. So I think we can take away an action to look at how within that work we can join it up, recognising that many children and young people with SEND and children and young people with mental health needs, that there'll be an overlap in the cohort, and we need to make sure that we fully understand those needs. So I think we can pick that up and bring those two pieces of work together. Thanks, Chair.
Thank you, Lucy. We've got two more speakers, Wheeler and Wilmot. I'm going to start with Councillor Wheeler.
Yeah, I just want to come back to the school session because given that the education system is incredibly fragmented, how do you plan to overcome those barriers? Thank you.
I think you've put it so well. It is going to be a real challenge in fragment services to try and get the integrated approach. I think really I'm going to be looking to sort of the experts in the field, for me, the education team, as to how they've done that with perhaps other agendas. I mean, we know that they were part of our task and finish group, and throughout the last year we have been discussing where the needs are, and my hope is they're going to continue to be part of our task and finish group for the strategy, so we can work on actually how are we going to have an integrated school approach and how will it be taken up. I think you have really shone a spotlight on something quite crucial, and it's something we're definitely going to be working towards together as a team. Thank you.
Lucy, you looked like you were going to say something in addition to that.
Yes, just to echo that, obviously as a Children and Families Department, we have a direct role in respect of some schools and an influential role in respect of academies, and are doing a lot of joint work around a whole range of issues, whether that's school attendance, trying to make sure that all children access their full educational entitlement. So again, it's around bringing some of these opportunities together so that when we engage with schools, we're doing it in a joined up way so that we maximise our influence.
We're going to finish with Councillor Wheeler. No, Councillor Wilmot. Councillor Wilmot.
Thank you, Chair. Yeah, I've got so much to say, but I'm going to cut it down because of the time factor.
No doubt we'll all be very grateful.
First of all, congratulations on this piece of work because it's very, very important. There are so many things happening in life, and suicide is one of the most things that we need to tackle in a big way. Really, it's a last shout for help. It really is a last shout for help, and it's due to the failure of the lack of help at an earlier opportunity. It's got to be, whether we call ourselves, the problem is our own, but that is the real problem. So how do we tackle it? I mean, again, I've got to go into early intervention schemes. The mental health problems, the eating problems of youngsters continually dieting in schools, that's incredible. I know of that because I've got a son that's a teacher, and it's happening so much at the present time that that is where we've got to start at schools. We haven't got the staff to go into all the schools all the time and so forth. So how do we combat it? We go into the schools and get the teachers to learn a little bit about what to look for. I mean, you've got 30 or 40 pupils looking, one teacher looking after them, all that amount of people. But they if they're educated enough to see what's happening, it might control the afterthought of a few years' time down the time that happens that the child might commit suicide at a later stage. So it's early intervention, absolutely. And as I say, identifying the problem at an early stage. It doesn't matter what sort of problem it is. There are hundreds of problems that can cause a person to go over the cliff edge, and that's I could go into other things, but I know time isn't available to move into other areas. But there is just one other area that those are financially vulnerable, unemployed, and people with a gambling problem. That is a very, very serious issue which is not being addressed. I don't know whether we ought to get some extra resources from the people who are getting all the cash, the gambling organisations, to help in that way. But we've got to put more money into that area to establish why people, as I say, are taking the terrible situation of committing suicide. Thank you.
Yes, thank you, Councillor Wilmot, as the final speaker there. There was no doubt about it that eating disorders increased enormously throughout COVID as people's way of controlling their own lives in an otherwise uncontrollable world, etc. And more recently, we put some money into schools to find kids living in homes where there's domestic abuse, etc., to try and pick out children who are in sort of dangerous situations, etc. I'm going to finish by just asking Safia if she wants to say a final word. Safia?
I just want to thank you for your questions, and I look forward to working with you, Lucy, on the children's side. Thank you.
I moved recommendations to approve the Joint Strategic Needs Assessment chapter on suicide prevention and to support the implementation of the recommendations within the context of a new Nottinghamshire and Nottingham suicide prevention strategy. I moved that with a second. All those in favour, and that's moved. So we are moving very, very quickly through to what is effectively the Chair's report. Normally speaking, we would have quite a lot of issues, but I'm going to keep it to a very short report. If we look on the more national basis, one of the things that has been shown to increase significantly over the last few years is oral cancers, gums, lips, oropharyngeal, throat, tonsils, etc., directly related to smoking and alcohol, and enhancing the requirements of us to improve access to dentists, etc., for oral reasons. We also mentioned earlier on the government's move, widely supported, where they want to ban single disposable vapes, and then 25,000 people surveyed, in excess of 70% of all of them were in support of banning the single disposable vapes. In terms of the actual report itself, I would like to bring people's attention to number one, the disability fund to employ people with long-term health disabilities across Nottingham and Nottinghamshire. And number three, 5.3 million. There is no single greater thing that you can put into a person's life than function and work, and distraction is the biggest treatment of all for any illnesses that exist. And I know people who get picked up and get brought to jobs and get home again, and it just allows them to live with their disabilities. I was delighted to see that as a sort of combined authority approach. One of the things that particularly caught my eye was the NHS lung health checks for cancer. In the country, we currently have probably 3 cancer screening programs. We've had cervical cancer, we've had breast cancer, we've had colon cancer. So you might think to yourself, hey, hang on, we screen for a lot of things. In reality, we screen for 3 cancers. I think that this could be the next one that we roll out. It started as a pilot project up in the north, where just CT equipment turned up and allowed people with a history of smoking or ex-smokers to come along and have their lungs checked. Of course, there are lots of other screening programs which are not for cancer, like aortic aneurysms, ultrasound scans for antenatally pregnant women, blood tests for newborn children, etc. So we've got lots of screening programs, but there must be more out there in terms of things like prostate. When are we going to get a proper prostate screening national program? But number 19 shows something which is working exceptionally well at picking up very early cancers in people with lung cancer, and giving a significant improvement in their survival rate. And Dr. Dylan Bartholomew's knows more about that and the future of the programme than I do. Dylan.
Yeah. Thank you, Chair. So one of my other roles is I'm the clinical director for the Target Lung Health Check program in Mansfield and Ashfield. Very quickly, so why lung cancer? Lung cancer is one of the big 4 cancers. So breast, prostate, bowel, and lung cancer. And why lung cancer stands out is, unlike the other 3, lung cancer, less than 30% are diagnosed at early stage. The biggest predictor for survival in cancer is diagnosing at an early stage. So lung cancer, it's about 30% which get diagnosed at an early stage. Obviously, that has significant implications. And it's a silent cancer because often when patients present as a GP, this cancer has already spread and it's presented in emergency presentations. So 5-6 years ago, there's a lot of research being done in Liverpool, Manchester, and also in Nottingham as well, looking at how do we identify cancers at an early stage. Then come 2019, 10 areas which were identified as having the highest prevalence of lung cancer with poor survival rates. Unsurprisingly, there was also a relationship with smoking, and Mansfield and Ashfield were among the top 10. So the Target Lung Health Check program is essentially inviting anyone between the age of 55 to 74 who have ever smoked in their life as an invitation, initially a screening process, then to identify if they were high risk, and then to get a low-dose CT scan after a nurse assessment, and subsequent of the diagnosis of cancer and some other incidental findings as well, and smoking cessation was offered. So in Notts County area, we have 3 programs. So Nottinghamshire, as I said, Mansfield and Ashfield went live in April 2021. the Targeted Lung Health Check program is coordinated by Cancer Alliances. Bassett Law does have one, and it's through South Yorkshire and Bassett Law Cancer Alliance. So it's outside East Midlands Cancer Alliance. Bassett Law went live in 2022, and Nottingham City went live last year. So overall, if you look at the numbers outside Bassett Law, because it's outside the East Midlands Cancer Alliance, we've had 150 cancers diagnosed across Nottingham and Nottinghamshire. Of the 2-year cycle in Mansfield and Ashfield, 110 cancers, of which 94 were lung cancers, 16 were other cancers, 8 urology, 2 breast, etc. What's really interesting is of the 100 odd plus cancers which were diagnosed, 62% were early stages, completely flipped the other way around, and 68% were curative diagnosis. So very clear, there's a bit of a typo error in 20B, but the numbers were, we invited over 20,000 odd patients, 17,000 took up the invitation. Mansfield and Ashfield had the highest uptake nationally, and there are reasons for that, which we've shared with the national program and which is now being implemented. Just under 9,000 were deemed as high risk, of which just under 7,500 had face-to-face nurse assessments, of which they all went, 7,165 had CT scans. Following that, the 100 odd cancers. So I think the key bits is these patients will be invited on a 2-year cycle, but the next stage is the expansion. So starting April, we are going another 22,000 odd eligible patients across Sherwood, as in Newark and Sherwood area. Arnold and Calverton and Byron Hucknall will be the next stage, followed on by a few years down the line with Rushcliffe, Nottingham was going on. So, and as you may know, Prime Minister and Health Secretary came last year because they visited the Nottingham City program, and the announcement was made by 2030, lung cancer will be the 4th national cancer screening program. As a national team, our aim is to get this rolled out by 2029, and Nottinghamshire will probably be the first county where we would hopefully have it rolled out across the whole of the county. So we are working in April to go live in Sherwood, as I said, Sherwood, Arnold, Calverton, and Byron, which is Hucknall.
I think it's fantastically exciting, Helen, and all of those people would have had smoking cessation offered to them.
Very quickly on that, I know Councillor Schiller wants to come in very quickly. And yes, we offer smoking cessation as well. And we've had, if I look at the data, we've had over 300 uptake, and the smoking cessation rates, 139 participants had quit within 4 weeks, and a further 95 had quit dates within 12 weeks. So that's also part and parcel of that. So the Councillor Schiller.
And let's not forget, smoking and lung cancer still the biggest killer in the UK. But it's looking joined up where we have a national screening programme, where we have a potential bill banning cigarettes, where we have put into try and reducing the single-use vapes, where we have our smoke-free Nottinghamshire hoped for 2030, and you can sort of see things sort of slowly coming together there. But that is very exciting. I won't ask you when prostate screening is going to come to the world, but I do think it's an enormously open time with the King having come out and started the discussion around cancer, etc. And it's a great opportunity. Councillor Scudder.
Sure.
And
you will get it right. Just to say, I can't praise this screening more. But the added bonus is not only the identification of CAs, it's COPDs as well, which is a huge factor in our post industrial phase.
Yeah, very quickly on. So, as the program said, it's lung health check, so it's not lung cancer screening, and you're rightly so. So, unfortunately, what happened was when the program went live, there was this pandemic which was happening in the background, so we couldn't do all what was intended to do. So, there's a significant identification of incidental findings of COPD, particularly for our areas with ex-mining heritage. We do that, and also it's also identifying 2 other risk factors, not risk factors, incidental findings is coronary artery calcification, which means that individuals at high risk of developing cardiovascular disease, and also around the heart valves as well. So those are the other things which we identify. But you're right to say that we are picking a lot more COPD patients at an early stage.
And severe COPD is a palliative disorder, so not to be trivialised in any way. Councillor Walters.
Knows my name.
I just wanted to add, on last Sunday I had my second scan. Excellent service, efficient, very friendly. Wham bam, thank you, ma'am. Great stuff. Carry on. That's it. Thank you.
Thank you. I'm going to move on, Councillor Wilmot, unless you're going to give some sort of thanks or some sort. Go on then.
Yeah, I'm welcoming the £40 million that's been put into to help people into employment with disabilities, etc.
Brilliant.
It's absolutely fantastic because 52% is not good, and I'm welcoming that, and I'm also welcoming the where is it? Oh, crikey. Sorry. Oh, there it is. Yeah, the cancer screening.
Yes.
I just wondered if we got any statistics of how many that smoking has caused that cancer, and if it has, if it's a big amount, it should be put in the newspapers, and to try and help people to stop smoking.
Percentage of
So 90% of all lung cancers are attributed to smoking.
Right.
So 10% of lung cancers are not related to smoking. So that gives you the headline figure. But then smoking, although lung cancer takes a headline, smoking is associated with lots of other cancers and other cardiovascular risk factors as well.
Finally, you've got projects that's been done by Bassett Law, Nottinghamshire, with everybody is doing something. It would be nice if it's a big success, it's shared with the other districts, so they can all get involved in the project that's a huge success.
So, as I said, so in terms of rollout come April, within the next 3 months, Sherwood, then Arnold and Calverton, and then Hucknall will be where the rollout will be over the next 2 years.
Fantastic update, Dylan. Just to say quickly, just a note to the Chair's report, we're going to go quickly into the work schedule going forward, and it's packed full of next one: housing, food insecurity, the forward plan, the community capacity, resilience, not to mention the suicide workshop, and then in July putting together 3 fantastic linked things around youth justice, children and care leavers, etc. So a packed work agenda. I'm just going to say we're going to move speedily through to our on the severe multiple disadvantaged, which, let's not forget, was Director Gribben's last director's area of priority, and he presented the paper to us, and this is the follow-up workshop to that paper. So coffee, biscuits, and let's move on through to the assembly rooms. Thank you.